What's up, everybody? It's David. I'm your host of Highway to Health podcast series. Thank you for being here. You know by now, this podcast is meant to celebrate the people, the organizations that are committed to improving patient access, patient experience, and of course, patient outcomes. And there's no better or more important community on that topic in this journey than the provider community, the clinician community, the nursing community. And that's why I'm excited to have this conversation today. You're gonna hear from Dr. Megan Carter. She's the president, she's the founder of MC Healthcare Consulting. She's got a great background, she's got a tremendous amount of experience and a really cool perspective on this topic, on where we are today, where we can get to where we want to go, and more importantly, what levers need to be pulled to find success. So, Megan, welcome to Highway to Health.
Thanks for having me.
Thank
so
you
excited.
for being here.
Thank you. Yeah.
Welcome to downtown Dallas.
Love it. Love
Fort
it.
Worth girl.
I am for now, but I grew up south of Dallas, so I love both.
Small town.
It is, yeah.
All right. So
yeah.
I already like you.
Yeah, there you go.
Yeah.
There's a bond between us small town folk for sure. Yep.
That's right. It's God's country.
It is. That's right.
But the city's kind of cool. It's got its...
It's beautiful.
It's
and the lighting outside's perfect right now. It's like this was meant to be.
Just
I love
for you.
It. Mm-hmm.
Yeah.
You know, I try. I send my request. Sometimes it gets granted.
Well, prayers, right?
That's right.
That's what we do.
That's right.
We're going to talk about a lot of things today,
Yeah.
but you know by now, my favorite topic, the way to start these podcasts is asking you to share a healthy habit, mental, physical routine that you've put into place. Helps you stay sane in this crazy world with this crazy schedule that you have. So what are some things that you do to stay at the top of your game?
I love that as a starter question, by the way. I think it's great. So for me, I certainly have a long way to go in perfecting that, but I do two things. So I make a list every day. I'm a list maker, and my 14-year-old son makes fun of me because I still handwrite my list, but it works for me so that I can sleep at night knowing that if I forgot something, at least I wrote it down, peace of mind. And I prioritize my tasks that way. And then just physically, I do Pilates. I'm a big Pilates believer. It's a good grounding and mental health and good community of ladies that I work out with. So do those two things, and usually that works pretty well for me.
Having a good community keeps you motivated, keeps you accountable.
Yep, absolutely.
And if the kid doesn't think you're crazy, you're not doing it right.
Correct, especially at that age. Yeah. Absolutely.
I've got a 13-year-old boy, and he looks at me like I'm wild and crazy every day.
Yeah,
so
you're on the right track.
We're doing it right.
Yeah.
I think. So I appreciate you sharing that. I think that's a big part to what all of our responsibility is. I mean, we've got to take some pressure off of the health system. The only way we do that is controlling what we can control and making sure that, whether it's diet, exercise, or mental health, that we're doing our part.
Right, absolutely.
And then when we need to rely on the health system, they're there for us.
Yeah.
And hopefully they continue to be there for us.
Yeah.
And we're going to talk about what's needed, for them to be there.
That's great.
You are a part of a really cool program. And we're going to get into some other things, but the Sacred Vocation program is pretty neat. Yeah. And I think it's done a lot, and I'd like to share your experience around the importance and what it's doing to help morale, retention in the nursing community. Yeah,
for sure. So to give credit where credit's due, so this program was created by the University of Texas Health Science Center in Houston.
Hook 'em.
So that's right. They're McGovern Center of Ethics, and so they created this program several years ago, originally for medical students because they were seeing burnout. And that group, it's a demanding program, and it has been so successful now it's spread to all of healthcare. And so there are several health systems. Baylor Scott and White here in DFW has employed it, and so I have permission from those folks in UT. I brought it to Kentucky, found it beneficial there at their health system. But long story short, it's designed to help healthcare workers regain their sense of meaning in their work. And we ask ourselves, why does that matter? Why is that important? You think about what a nurse or a physician faces when they walk into, let's say, a hospital. People are dying, people are suffering, they're there to do good. It's very emotionally demanding. And so if you do that for several years and you deal with a lot of extreme situations, you can burn out, you can feel jaded. So this program really helps you take a step back. Let's reconnect with why we got into healthcare in the first place, but let's also build some realistic coping tips moving forward. And one of the basic principles is choosing to be a healer in every interaction instead of a harmer.
Okay.
And remembering that we have control of that. It's not outside of us. Our locus of control is internal.
Yep.
And so if, even if I'm faced with really difficult situations, maybe there are people yelling, maybe it gets crazy at work, if I choose to show up in a healing way instead of a harming, when I go to sleep at night, at least I know that I've done what I can for humanity. And so we work through that in 5 different classes with them. And when they graduate from the program, they've actually created their own sacred vocation oath that they'll take together out loud in front of the leadership team to create some accountability for choosing to show up in that healing way.
Internal locus of control is important.
Yeah.
We can't control how we're treated,
right?
But we can control how we react.
Exactly.
Man, that's easier said than done.
For sure.
Especially for these practitioners and these clinicians. So it's important work. The why is important, but you also have to show them how.
Right.
How they can cope and how they can work through these things. Burnout is it's not just a big topic right now. It's kind of a scary topic.
It is
right now.
Yeah.
In healthcare, and nothing happens without a clinician, without a provider of some sort.
Right.
We can talk about scalability and automation and all these things that are kind of shiny objects in healthcare right now. None of it matters without the provider.
For sure.
And that provider needs some support.
Yeah.
That provider needs a lot of TLC.
Yeah.
And I want to talk a little bit about that today. But before we get there, what are some of the things? You're in these hospital systems, you're in these health systems almost every day, talking to these executives. They've got a million different priorities on their plate.
Yeah.
A lot of them are financial priorities.
Right. Sure.
No margin, no mission.
Right.
But what are some of the things that we've got to start thinking and prioritizing to prevent this burnout at an executive level?
Right.
What can we start doing to improve morale and retention and lower the burnout rate for our providers?
Yeah, some of it starts with breaking up this historic culture, this mindset of martyrdom. So I say that to mean, when you grow up in a school of medicine or a school of nursing, you go into it with altruistic intentions. So we're here to put others before ourselves. That's our higher calling. It's noble, it's wonderful. The problem is, though, over time, you can be pulled into workloads and workflows and hours that exceed your mental and emotional capability. And again, you extrapolate that over several years, you're putting others before yourself at the cost of your own self, at the cost of your mental and emotional health. So how do we do that? How do we break that up? Part of it, one example I'll give is as leaders, as the exec team, we start normalizing conversations around mental health that historically it was a taboo topic.
Right.
Physicians and nurses don't want to be seen as mentally unwell because then they're not seen as capable. But as leaders, if we can go into the departments and interact with our physicians, nurses, all our clinicians and say, what are you doing this week to take care of yourself? I'll tell you what I'm doing. Something as simple as that, and normalizing having the conversation and making it okay to talk about. And if someone's feeling mentally unwell, having resources right then and there ready to provide them, and then give them the time. If they need to take time off, it's easier said than done. I know everybody's shorthanded, but I think creating the conversation, creating a safe space for them to talk about those issues as the executive or as the director, and then they feel comfortable coming forward and asking for help when they need it, I think is a really good place to start.
Yeah. I mean, you've got to identify and realize before you can start to remedy.
Yeah.
I'm glad you didn't say the answer was technology.
Yeah. It's a two-sided coin. It's a blessing and a curse, yeah.
A lot of times, and nothing wrong with this, a lot of times we think the answer is a new widget, a new automation, something that, in a perfect world would save time, give them time back in their day.
Yeah.
I've actually seen technology is almost starting to become a bad word in healthcare, especially with the clinicians, the providers, the nurses. Why is that?
So I love that you asked this. I think there's a long history of how we implement that technology. And I think there are organizations in the country who've done it really well. And those that do it well have typically, for example, roles like informaticists. So nurse informaticists, physician informaticists who speak both languages. They roll it out in a way that makes sense for both parties, right? Tech and frontline. But there are a lot of places that don't have those resources, or from a time perspective, patient safety perspective, they've had to roll out the technology quickly. And the problem is with the pace of change where it is today in 2024, you're rolling out new things so quickly, you're not allowing that cognitive space, that learning curve for the clinicians who are just trying to take care of patients, right? They just want to take care of people, giving them the space to really adopt, understand. It's that change management approach. A lot of places really struggle with that for the reasons we just identified. They're spread super thin. They're trying to just take care of patients. So it's not like you can take the whole hospital employees out for a day, shut the hospital down, and do a massive orientation. You have to be very intentional with how you roll it out, how you educate. And just because you showed them how it works doesn't mean that they like it. You know, we're very change averse as human beings. It seems risky, especially when you're dealing with human lives. So to me, technology can be a friend, it can be a colleague, a good word. It's just we have a long-standing history of not doing it well in healthcare, but we're working on that.
Yeah, I mean, technology comes at a cost.
Right.
At the end of the day.
Yeah.
A financial burden.
Right.
You know, and commitment.
Right.
But also, there's a ton of time that gets allocated towards a new piece of technology. Not just the implementation. The implementation could be perfect. The integrations could be perfect. The user experience could be great. But it takes time to learn something new.
It does.
And that's something that nurses, clinicians don't have at all. I mean, they just don't have any extra time to learn something new. And so maybe, have you seen something go, you know, be implemented, adopted, and enjoyed at a high level by these providers? I mean, how is it done well? If it's ever done well, how is it done well?
I've seen I've worked with a lot of big electronic health record companies, and I've seen organizations that do it really well. So an example I would give is an organization that has Epic as a system, and they're doing a massive upgrade. So they're either going to put new workflows, new all kinds of things. What they did well is from the get-go, as they were designing the new workflows, they brought physicians and nurses to the table. They showed them the workflow, and they said, does this make sense? And they were free to say, absolutely not. That's going to cost me 10 minutes, whatever. So they were willing to update the workflow according to that feedback. And then when it came time to roll it out, those clinicians were the champions themselves, going out and showing people how to do it. If I can catch you while you're, you know, in a clinic doing patient care at the elbow and give 30 seconds and say, hey, David, here's how you chart smarter, not harder, you're going to be so excited about that. You're going to adopt that quickly, and it's going to become permanent instantly. So I think that's a great example of implementing technology in a really smart way. I
agree. It's got to be, you know, physician-led or nurse-led. Because they're the ones that, you know, they're the boots on the ground. They're the front line. But that usually takes time. Usually takes money. They're probably doing that on, you know, their day off, or having to be, you know, you're having to pay them overtime to provide that feedback. And that's where this balance of efficiency, margin, expense, but also compassion comes into play. How can healthcare strike that balance?
Oh, it's such a great question. That's $1 million question. I think that's what executive hospital leaders do on a daily basis. They're trying to balance all of those priorities. So it is my belief that every healthcare leader wakes up in the morning, goes to work with the best intentions to ease human suffering, support the precious people doing the sacred work. It's just that the reality of all those competing priorities you just listed as a human being and trying to make sure you're getting everything for everyone, I think gets really, really challenging. So I think part of it is just having good mentors, having good support system, having great resources so that you can do all of those things.
The reason we're talking about this is because, you know, we talked about retention and we talked about, you know, the shortages at the beginning of this conversation, but you know, all of this stuff plays into the experience that this clinician, this nurse is dealing with every day. And which affects burnout. And if we're losing these clinicians at a rate that we can't replace, that puts us in a scary place 5, 10, 15 years from now.
It does.
You know, I think about my parents and the age they are. I think about my kids. I mean, I think about myself, right, and all my loved ones about, you know, who's going to be there to take care of us when we need them. Talk about, you know, give us a state of the union. I mean, I don't want to be doom and gloom. But we need to understand the actual state of where we are in this space.
No, I appreciate that. So I'll say this to say my intention is not to create doom and gloom, but I think people who are outside healthcare probably just don't understand that there needs to be a sense of urgency around addressing this because it affects every single one of us. We all need healthcare at some point in our lives, no matter how healthy we might think we are. So I had some statistics that I brought with me, but I can tell you that the Bureau of Labor Statistics through the U.S. government predicts, you know, they do projections by industry of staffing shortages. And so for RNs in the United States, they look at all 50 states, and Texas is on track by 2030 to be number 2 in the nation for the shortage. And you don't want to be
second biggest shortage.
Yeah, you don't want to be at the top of that list. You want to be at the bottom of that list. And part of it is certainly our size and having rural communities, but even when you adjust it by population size, California's on track to be number 1, we're on track to be number 2. Yeah. So that's one stat that should really worry people and help them get involved in the solution. The other statistic I'll give is there's a group of nurses we know are leaving the workforce en masse because the median age is around 46. They're looking at retirement.
Yeah.
Who can blame them? If I could afford to retire today, I'd do it too. I get it. But there's another group that are under the age of 35 that are leaving for all the reasons we just talked about.
Yep.
So these people that are supposed to be our future pipeline are experiencing healthcare where it is today and saying, no, thank you, I don't want any of that. And so that should be really concerning to folks.
It is concerning because usually not only we can't lose them at 35.
Right.
We need them for another 10 years.
Yeah.
But also, you know what happens if somebody's having a great experience as a nurse is, their kids
Right.
recognize that mom or dad is having a great experience at work and providing a great life for their family. And
Right.
they want to be a part of that community.
Right.
They want to be a part of that profession.
Exactly.
And so, yes, we're losing them early, and then the pipeline is,
Right.
Who's coming up hoping to be in this profession if this is the State of the Union.
Right.
And then the other thing is, if they're leaving the profession, are they teaching?
Right.
Are they going back and providing education to those that are in school?
Right.
It's a domino effect. It's a
Right.
compounding
Right.
problem, and something that we've got to address in a lot of different ways. And I think that's why the leadership, having strong, nursing, clinical leadership in the health system is so important. You've seen some of these things firsthand.
Yeah.
Talk a little bit about the typical structure at a health system versus the ideal structure at a health system when it comes to that type of leadership.
Yeah. So without stepping on toes, just my humble opinion. So I'll give the disclaimer.
That's all this is.
This is Dr. Carter's humble opinion.
Opinions.
But I've worked in some organizations where the chief nursing officer, the chief medical officer, and then your chief exec officer are one and the same from an org structure. They're a triad, they're equal. And when we say that, it's not about pride or title, it's about the level of autonomy that each of those executive leaders has to make decisions for their group. So for example, if we know nurses make up 60 to 70% of the healthcare workforce, you really want that chief nursing officer to be able to pull levers quickly when there's a crisis. You want them to be able to be at the table when we're deciding if we have X amount of dollars to spend, what's the safest place to spend it for the sake of the patient.
Right.
Same with your chief medicine officer. Some organizations I've seen where the CNO reports up to a VP who then reports up to the CEO. And again, not about pride or title, but level of autonomy and authority to make decisions that need to be made quickly, especially in a hospital setting. So, my humble opinion is if your workforce of nurses is that large, which it is for 99% of the time, your CNO, your CMO, and your CEO have to work in tandem together to be able to pull those levers.
And I think that's the right balance of efficiency and compassion.
Right.
If the government was working perfectly, there would be checks and balances in place.
Right.
And the same goes for our health systems.
Yeah.
I mean, we've got to keep patients top of mind.
We do.
And to do that, we have to have the clinicians top of mind.
Right.
And yes, there comes a dollar amount tied to those things, and that's why there is a CEO and a CFO and these other elements. But if they're not peers, one's going to take precedent over the other.
Exactly.
Tell me about you mentioned rural hospitals.
Mm-hmm.
I've got an idea on how they're handling this shortage today because that's the community I live in. But how are health systems addressing this shortage today? Are they going and hiring travel nurses? What are they doing? Are they investing more in technology? What's the common approach here?
So not to speak on behalf of all of them, but in my experience, especially in rural communities, it's very difficult to attract talent to a rural place unless that's specifically what they're looking for, especially younger folks. So a lot of these rural hospitals are still to this day spending millions of dollars on travel nursing, which, let me be clear, we're grateful, so grateful for travel nurses. They are filling a need. As we discussed what the shortage is, it's wonderful. But because it is so expensive in these smaller rural hospitals, they don't have a ton of money, if any. So we're seeing some of them close their doors altogether, which is heartbreaking. That's truly a safety concern for that community. And then they're doing whatever they can to retain the precious talent that they have. So they are really struggling. Another angle on that is nurse practitioners. So what we call physician extenders, PAs, nurse practitioners. Here in Texas, NPs don't have full prescriptive authority. We're one of a few states in America that hasn't granted that from a legislative perspective, and there's lots of reasons why. But unfortunately, when you've got all of these NPs who could be out there functioning independently and providing precious health care to people in rural communities, that gap continues to exist, and so people continue to suffer because of that.
What kind of financial burden? You mentioned millions and millions of dollars on these travel nurses. What's the gap there? How much does a travel nurse cost compared to a nurse that's in-house, that's on staff? Anywhere
from 5 to 7 times what your average RN salary typically, and that's what you're paying the company.
Right.
That's staffing. And
they've got to get their margin.
And the reality is, we talk to each other, right? If we're at work, if I show up and we're asking, because I might be interested in being a travel nurse. Hey, how much are you actually making? I don't blame them for being drawn to it. They're getting paid more in 6 months than they have in the past 2 years. If they're paying for housing, that makes a difference for my family. Absolutely. But it's hard for the nurses who are part of the core staff in that department who are hearing this thinking, man, I could be doing the same thing. So as a leader, you're really caught between these two competing perspectives, and how do I manage that?
I just think about the finite number of dollars that are available to the health system and the impact that has on
it's huge.
On other things.
Yeah.
It's got to put other purchases, other investments on the back burner.
Yeah.
Probably even some high priority things.
Absolutely. Basic equipment. Yeah.
Basic equipment.
Mm-hmm. Yeah.
Beds.
Right. Ventilators.
Ventilators.
Yeah. Mm-hmm. Yeah. Impacts all of that.
You got to have people before you have the equipment, and so think about that. I mean, yes, worst case scenario is they have to shut their doors.
Right.
Especially a critical access hospital like the one that we depend on.
Right.
But it could almost even be more harmful to the patient if I go to the facility, I go to the hospital, I take a loved one there, and they don't have the basic equipment that I need because they've invested the majority of that money into these travel nurses. It's a problem that affects every area of the healthcare experience, and absolutely the outcome for the patient.
Yeah.
So we've got to improve. We've got to improve the experience for these nurses. We've got to do a better job retaining them and then attracting top talent too.
Yeah.
Otherwise, this problem that certain pockets of the country are facing and really feeling is going to be more common to the general population.
Yeah. It will be interesting to see as, we have different generational groups of patients, right? So we've got, currently the largest portion is our baby boomer population, right? And so they're coming in, they're living longer, more comorbidities. So the question will be 20 years from now, 30 years from now, when maybe they make up less of the population as we all age out, will the demand still be high? So there are a lot of people trying to look towards the future and wonder, is this crisis, will it be self-resolving from that perspective?
Gotcha.
Or is there going to be a whole new level of need that we haven't even predicted yet?
Yeah.
Yeah, ever moving.
I mean, Elon Musk always talks about the depopulation of the planet, so maybe it'll solve itself 100 years from now. Who knows? That's a whole other conversation.
Yeah.
So where do we go from here? I mean, we talked about, improving the experience and being physician-led or nurse-led, practitioner, clinician-led in the health systems. We talked about how technology can be seen as a positive sometimes if done correctly, implemented correctly.
Yeah.
What does legislation play in this?
Oh, everything. Yeah. So I'm so proud of our state. So I will say during the pandemic itself, the state of Texas did a really great job. I know I can compare because I started the pandemic living in a different state at the time, but having come here, our state legislation approved, they themselves paid for regional advisory council groups to have nurses brought from all over the country. They bus them in. Literally, we'd show up to work. There was a bus full of travel nurses ready to roll in and help us save lives. Fabulous. Not sustainable long term, right?
Right.
So some of the legislative conversations are, okay, now we have a case study. We know what difference these nurses and these physicians make. How can we make it more affordable for them to go to school? One of the big legislative priorities for the state of Texas and at the federal level we've discussed is making sure that we're paying these faculty and these instructors more competitively. Right now, I would make far less as a faculty member in a doctoral program than I would just being an entrepreneur out on my own. So the desire to increase faculty and increase the number of graduating students there's a mismatch there. So that's one of the things. And we also talk about protecting healthcare workers from violence. So a lot of the community may not realize this unless they've been in the hospital recently, but we're seeing a dramatic increase in workplace violence against healthcare workers.
Yep.
Some states are starting to pass legislation that make it an actual, the same level of offense it would be if you attacked an airline worker. So we've all probably seen viral TikTok videos of people acting out on an airplane. We see the airline workers come and address them. You need that same level of seriousness and authority to help prevent some of that behavior.
Absolutely.
So we're looking for support at a state and a federal level for that, and some states are starting to pass that kind of legislation. So, I mean, the list is long. There could be 20 different examples, but nurses and physicians getting more active and actually showing up to these meetings and realizing that they can provide powerful perspective. Because if I'm a legislator, I've got 100 bills I've got to say yes or no to today. Tell me a story. Like, help me understand if I'm going to vote yes or no and I've not walked in your shoes. They want to hear from us. Yeah. So we really need to do a better job of getting folks to the table to kind of push for that.
And we should have an advantage in healthcare.
Right.
We have the best stories.
We do, absolutely.
And everybody's a patient, so how does it not?
Yeah. How could it not be compelling?
Or be relevant, yeah.
Yeah.
We talked about, you mentioned some things that we could add and we could do. Right. Is there anything that we could take away? Could we eliminate some stuff that might be providing congestion or, unnecessary burden? Yeah.
So one of the things I do in my consulting work called the Clinician Refocus Framework is we do what are called time motion observations to pick that out specifically. So for example, I'll shadow a nurse with my tablet and my software, and all I'm doing is documenting the tasks that they're doing, how often they're getting interrupted, and how much time they're spending in that task. Well, if you do that for several hours over several shifts, you start to see a trend emerging. And so what we do is we do a baseline evaluation like that. We roll it all up together and say, okay, the first 4 hours of your shift, we've observed 20 different shifts. You're only spending an hour of your time on actual patient care.
That's crazy.
The other 3 hours are spent trying to document, being interrupted, running back and forth for missing things. So there's a lot of waste that could be taken out. We did see a rise in what we call lean Six Sigma approaches in healthcare, and that's worked well in pockets. I think the opportunity for improvement in that approach is really understanding that the work that we do when we're dealing with human beings is not predictable work.
Right.
There's nothing linear. No two shifts are ever going to be the same. No two patients are ever going to be the same. So actually having a time motion observation to capture all that complexity, quantify it, and help us make smarter decisions and remove a lot of that waste out is really impactful.
I bet that data is helpful for certain members of the decision-making process.
Yes, it is. Yeah. So, you've got leaders, our leadership teams at healthcare organizations, they all have different backgrounds. You ideally have people with some clinical experience, but a lot of them
they probably
aren't.
get it right away. Like the clinical experience people are like, wait, you're going to make my nurses' lives easier?
Right.
I'm all for it. I'll write the check right now.
Right.
But not everybody.
But the non-clinical folks, it's just we've never walked in their shoes. We just don't get it, and that's okay. There's nothing wrong. Best of intentions, but when you can show them the data of how they're actually spending their time, we're not just telling stories now. We're showing you quantitatively how difficult and complex it is. No wonder we have so many adverse events and medication errors. Because look at the complexity of what they're doing. This is nurses and physicians. This is everybody. You can do this for any role.
So they see the data, they probably see an opportunity to save some costs, save some time.
Yeah.
But then you add patient outcomes.
Which is the whole reason, right.
Which also has a financial
absolutely
result to it too. So now you're starting to talk the CFO's language and maybe even the CIO's language a little bit more. Now you can get some true movement, some true traction. Yeah,
we talked earlier about incremental overtime. So, I've worked with so many great CFOs, and most of them in healthcare, they're very patient-centric. I mean, they're in healthcare for a reason. So if we can translate dollars and human experience, it's always a win for everybody. But I'll take something as simple as, how long are your nurses and docs staying past their shift just to catch up on documentation? Think about how much you're paying them on an hourly basis. If we can reduce that even by an hour times 100 people, there's a huge return on investment just right there. That's just one example. Yeah, absolutely.
What's the one thing that you want our listeners to remember after today?
Your nurses, your physicians, all of your clinical folks are doing the absolute best they can. They care deeply about you. They're there to keep you safe. The environment that they're working in today is not what it was 10 years ago, and they're just trying to survive. So please be kind to them. Please be patient with them and trust that they're there to do the right thing for you.
And nothing happens in healthcare without them.
Correct. Yeah, absolutely. Yeah.
I appreciate you being here.
Thank you so much. I had a great time.
You're welcome back anytime.
Thank you. Awesome. Thank you, David.